Greetings, everyone. Thank you for attending or watching this presentation. My name is Ponar Samad. On behalf of my colleagues, who will be presenting this paper titled Non-Transfer Deep Learning of Optical Coherence Tomography for Post-hoc Explanation of Macular Disease Classification. So this will be the outline of our presentation, and I will go directly to the background information. So macular disease condition, age-related macular degeneration, AMD, is one of the leading causes of blindness in elderly population over the age of 75. And diabetic macular edema is another particular condition which is characterized by fluid-filled cyst and hard exudates in the retina due to leakage from damaged retinal blood vessels. So all these conditions are being classified or detected in clinical practice using optical coherence tomography, in short form it's OCT, which can capture a cross-sectional view of the retina and optic nerve at micrometer resolutions. Now, to aid the clinicians so that they have a second opinion on their diagnosis, it's important to have a computer-assisted diagnostic tool. So to aid and optimize clinical decisions, computer vision approaches, for example, deep learning methods can help clinicians classify different states and conditions of macular diseases such as AMD and DME using OCT images. If we look into the deep learning, the current status of the deep learning, there are a lot of papers and a lot of studies that use transfer learning under the condition that when the study has a very small sample size, when the sample size is limited, there is a risk of getting the model overfitted. So to circumvent that situation, so one of the ways is to use a pre-trained deep neural network. For example, we can use Inception V3 architecture trained with ImageNet dataset to classify macular disease in OCT images. In fact, we can use this pre-trained model to classify images when our training and test samples are not good or large in number reasonably. In the same way, we can use VGG16, Inception V3, and ResNet 15 have been used in this particular OCT classification examples. Now, one of the things that has been identified in the literature is transfer learning does not perform well on OCT images since low-level filters are color dependent. Because one of the things we need to consider that once we have these 16 convolutional layers in this pre-trained deep neural network, and these layers are basically trained by natural images, which have multiple color channels, whereas our medical imaging can be dealing with monochromatic images or images in the spectral domain. So one of the things that we try to bring in this paper is let's try to train and test the model from scratch, deep learning model from scratch without using any non-transfer to be able to see how far the deep learning itself can go. And by doing so, we should be able to provide some sort of visualization as well as explanation. So if you look into the literature, we see that there is a paper that uses a lightweight CNN that involves only 2 convolutional layers for OCT image classification. So the idea is, what is the minimum number of computation you can deploy to be able to do OCT image classification? There is a paper that used the OCT image features at different convolutional layers, and they visualize those images to be able to explain what's going on and how the deep neural network is learning those particular features. So these are some of the papers that inspired our work. And then we have another paper that visualized the OCT image features after the fully connected layers. And as we know in deep neural CNN, convolutional neural network, we have a cascaded layers of convolutional operations which do the feature extraction part, and then we have the fully connected layer that does the classification part. So in this particular visualization box, what was done is the very last feature towards the end of the fully connected layers were used for visualization to understand how discriminative those features are after doing the deep learning. So here the motivation is, let's try to do the deep learning from scratch for these OCT images. And the hypothesis here is we assume that OCT images are monochromatic images, and that's why they do not need the hefty multicolored channel for those filter convolutions. So the first motivation here is to provide some sort of explainability, because if we are using transfer learning, we argue that a pre-trained neural network model that is trained with natural images may not provide intuitive information or explainability when we are trying to fine-tune similar models using medical imaging. So medical imaging can be monochromatic, and OCT images are also called spectral imaging. So how does a clinician explain the images misclassified by CNN? So for example, if we know that a particular model, if a deep CNN model is misclassifying certain images, how do we explain that why that model misclassified those images? Model optimization, do we really need 16 layers of transfer learning? And the next question that we try to ask is, are all CNN filters useful? A subset of sufficient filter kernels for macular disease classification may be good enough to get us to the maximum or the best or the optimal possible classification accuracy, as well as we try to visualize the features extracted at the last convolutional layer in 2D space to see how the limited number of convolutional layers are learning those discriminative image features right after the convolutional operation. So these are some of the example images coming from the OCT dataset. So for this dataset, we used a clinical OCT image dataset sourced from this reference for macular disease classification. The dataset includes about 84,000 OCT images from follow-up studies of 4,657 patients of diverse races, ages, and gender. And the image samples are clinically labeled into one of the four classes: normal, which include patients that do not exhibit any type of macular disease conditions. And then we have three distinct disease conditions. One is the CNV, DME, and drusen. So in terms of the method, what we did is instead of using black box high-level APIs that most of the research studies are using these days, for example, Keras or PyTorch, what we did is we used the mathematical expressions of TensorFlow, and we developed a highly configurable convolutional neural network so that we can fine-tune the neural network at a very low level whenever needed for explainability. So in the model architecture, what we did is we had a set of training data and a set of validation data, and we fine-tuned the model to be able to find the best hyperparameter settings in the validation step, which is then used to train with the training plus validation data set. And then we tested with the left-out test data set. And this is what the final deep neural network looks like, where we have 5 convolutional layers and 2 hidden layers in the fully connected to be able to do the final full class classification, as you can see over here. So let's move on to the results. So these are the filter responses coming out of filter convolutional layer 1. So we're just taking a screenshot of many numbers of filters. As you can see, most of these filters have some sort of responses. And as we move on to the second convolutional layer, the responses look pretty much full across multiple different images. And as we go along, if we move to the final convolutional layer, which is the responses after the 5th convolutional layer, as you can see, most of these filter responses are sparse, and only a handful of those filters are producing non-sparse responses. As you can see, these are the blobs. So ideally, what we can do is, if we can just take only these 8 filters at the 5th convolutional layer, to be able to extract and utilize our final features that will not only reduce the number of computation or number of convolutional operation whatsoever, and that will also help us reduce the dimensionality and help us better explain how the model is behaving, to be able to explain, to be able to classify a particular OCT image. So what we did later is we took the responses of those 8 filters instead of taking the sparse responses all over that we did. So for the model selection, we did the hyperparameter tuning using the training and validation data set. These are the hyperparameters we ended up using. And this is the confusion matrix. And as you can see, most of the classes were fairly well classified, except for the CNV, except for the true labels. Here is the Drusen. So 15 of those Drusen examples were misclassified as CNV. And later in the slide, we will explain some of those misclassified examples. And then what we did is we compared this accuracy, the performance of our model with those reported in the transfer learning literature. So as you can see, all these examples, as you can see here, are one way or other are using transfer learning techniques. And what we are able to show here is our non-transfer CNN was able to achieve the best accuracy when compared to the transfer learning approaches. So that gives us a question that do we really need transfer learning to solve all types of problems. So like we mentioned that we took only 8 filters response out of 256 filters at the 5th convolutional layer. So the final convolutional layer. And then what we did is those 8 filters were contributing 1,352 dimensional features, and then we projected those features into 2D subspace. And if you just simply use a PCA, and what we can see here is the PCA 2D coordinate in the X coordinate, in the first coordinate and the second coordinate. And the interesting observation is the normal patients are centered at the coordinate origin. And the other 3 patients are distinctly scattered across their own direction or own path within this particular coordinate. So what we can see is, even though we have a very high dimensional image features, even in a linear data dimensional reduction techniques such as PCA was able to identify the region or the manifold of those particular patient groups very fairly nicely. And then for visualization purpose, we also use the t-SNE. And as you can see, the normal patients are mostly centered across around the origin of the 2-dimensional coordinate space, and the other patients are diverging from the center to their distinct directions. We would like to explain some of those misclassified images. So what we did is, one of our co-authors is a practicing physician. So we try to take some of those examples and we try to explain 20 of them, but just for the sake of time, I'm going to show only a few of them. So in the first image, as you can see, this was a normal image, which was misclassified as DME because of the presence of an image artifact. And then we have another image in this particular case where CNV was confused as DME due to the presence of intraretinal edema pattern like DME. And then we have another example where the DME is misclassified as CNV because some shadowing on the subretinal area. And then the final image that we see here, this particular image was even challenging for the clinician to classify. This is a challenging Drusen example, which is actually a Drusen example, which may appear as CNV to an expert clinician because there are some confusing or common patterns that may create that type of confusion for both the convolutional layer CNN as well as to the physician. So discussion in non-transfer deep learning in this particular case is preferable over transfer learning. We do not want to really invest a hefty dense neural network for that. Low-level and non-transfer implementation of deep CNN has eased the path of explainability when we have found only a small subset of filter responses are useful. Non-transfer learning yields sufficiently explainable features, and clinical interpretation of misclassified images can be taken into next step for model optimization to yield near perfect classification accuracy. Now, in conclusion, transfer learning should not be the default choice for all medical classification problems. We really need to think carefully, looking at the complexity of our images. Does it really need that level of convolutional operation or that level of deep neural network or not? For monochromatic medical images require less computational resources. The visualization of high dimensional image features reveals the effectiveness of corresponding selective image filters, and clinical interpretation of deep model response may help in further optimizing the model performance. These are the references, and I thank you for your attention and would love to have your question. Thank you.